Excited.
Okay, well, thank you so much for having me here. It is my first time at this so far wonderful conference. I am delighted to discuss whatever you call it, this paper by Pauline Mourot. I'm delighted for two reasons, really. One is that, sometimes authors make this joke or like, if you don't like something, blame my co-author or whatever. It's actually true here. Anything you find objectionable, you should direct to the author of the paper. I am but the messenger. No, the second reason I'm delighted is because you won't find anything objectionable. I'll say right at the top, it's a great paper. I loved reading it. I've seen Pauline present it before in Chicago, and I'm so excited that this gives me an incentive to engage with it more deeply. So stay tuned for a really cool thing. Okay. So the motivation for this paper is that, the question of worker sorting across firms is very important and a long-standing research question. And the kind of way that I like to think about it in a kind of little bit more of a sexy, zesty policy way is, what is the value add of firms? What are institutions actually doing beyond the workers that they employ, right? What is the value add of these firms? You can think about this in the labor market. So all this literature going back to John Avow's work, where they try to sort of decompose the variance of wage distribution within firms to see whether it's like a worker productivity thing or a firm productivity thing. A lot of the newer literature in this space is really going to inspire Pauline's work here, which I'll talk about a little bit later. You can think about this in the education context, going back to Dale and Kruger. What happens if you take a student at a lower ranked university and sort of put them at a higher ranked university? What happens? What is the institution actually doing here? Now in healthcare, which is going to be the focus of this paper, you obviously have a large variation in quality and costs, well documented across providers and across hospitals. And there's been a lot of literature trying to demonstrate this variation in quality. So if you think about physicians, you might think about, random assortment of, physicians to patients in an ER setting. You can use that to exploit what physicians are actually doing. If you think about hospital, you can, talk about the randomness of ambulances going to hospitals, like those Doyle Guru papers to think about what hospitals are actually doing. Where this paper is coming in is it's going to look at the interactions of physicians and hospitals, right? It's going to think about to what extent are physicians the drivers of health production, or is it hospitals? And sort of, again, what are the value add of hospitals beyond the physicians that they employ? That's the way that I like to think about the big question of this paper. And so is variation in any hospital outcomes coming from physician sorting, or again, is the hospital actually doing something? That's where this paper is fitting into the literature, a question that is somewhat understudied. And so that's why I like it a lot. So specifically, this paper is going to look at surgeons, and it's going to ask three specific questions. The first is going to be, are surgeons and hospitals complements in the production process, or are they substitutes? Complements in the sense of, do top surgeons perform better when they're in top hospitals, right? Do you want the top surgeons to sort of the top hospitals? Substitutes, the opposite, right? So that's the first question. The second question is going to be, do surgeons at baseline positively or negatively sort across hospitals? What do we actually see in the data? And then the third, synthesizing these first two questions, we're going to ask, is this sorting optimal, or is there another way that we can do it? The context in this paper is going to be coronary artery bypass surgery, CABG, which is going to be advantageous because it's very popular among cardiac surgeons. It's going to have a very clearly definable measure of outcome, which is 30-day mortality, and this great data using Medicare claims data. And the method of this paper is it's basically going to be using a two-way fixed effect strategy, although I think Pauline would probably resent me saying that because it's in fact a little bit more nuanced and a lot more complicated, which I will get to a little bit later. There's a lot that Pauline does to convince us that a group fixed effect approach in the spirit of some of these like BLM 2015 models work in this setting, as well as control functions using discrete choice hospital demand models. I'll go into that a little bit later, but that is what this paper is basically going to do. And what is the paper going to find? So let's think about those three questions. Question one, are surgeons and hospitals complements or substitutes in the production function? This paper is going to find that they are very clearly substitutes. Indeed, top quality surgeons tend to have similar outcomes regardless of the hospital that they're performing surgery at. But top quality hospitals add value, particularly to low quality surgeons that perform there. So they're substitutes in the production process. Question two, do surgeons positively or negatively sort ex ante? Positively. Top surgeons go to top hospitals. And so if you take these two facts together and you try to answer question three, is this sorting optimal? No, it's not optimal at all. The current allocation, in fact, you're going to find is worse than if you just randomly sorted physicians into hospitals. And in fact, in counterfactuals, Pauline's going to find that if you negatively sort physicians across hospitals, that's going to result in about a 25% decrease in mortality, which is a pretty stunning number, in my opinion. So that is this paper in a nutshell. Let me go through very briefly the setting and the data of the paper, talk about the empirical strategy, results, counterfactuals, and then I'm going to throw in my discussion at the end. Okay, so this is going to be CABG surgery. Most people in this room, I don't think I need to explain much about this to, but just for a bit of background, it's an extremely common procedure, about 200,000 patients per year. Most of them are older. So 40 to 50% of patients are 65 and older. It's a very costly procedure. The average cost per stay is on the order of $46,000, $47,000. And the total cost per year is about $7 billion for this procedure. It's extremely complex. It is performed by specialty cardiac surgeons. It takes about 3 to 6 hours per procedure. And a big note here is that it's a large fraction of cardiac surgeon activity. It's the most common surgery on average for their Medicare patients. So extremely common, extremely costly. And another benefit about it is that the outcomes are clearly well defined, right? So in the paper, we're looking at a health outcome as the 30-day risk-adjusted survival rate, easily observable. It started being reported in the 1990s as part of these report card programs, and it's reported by CMS. All these great reasons we might want to use this as an outcome for this specific surgery. And just the data that Pauline's going to be using is claims data for traditional Medicare between 2011 and 2017, in which she's going to take a look at the professional surgeon claims from the data, match it to hospital stays. Right? I mentioned, great thing about this outcome is that it varies quite a bit by provider. You can actually just sort of see that here. If you plot the 30-day risk-adjusted survival rate across hospitals, you can see that there's quite a bit of variation. The standard deviation is about 0.02, which is about half of the mean mortality rate. Okay, so this is pretty substantial variation. It actually kind of looks the same when you do it for physicians. And the reason I put this graph here sort of in the beginning is because it's a nice motivating graph for what the paper is trying to do. Because these kind of distributions are quite correlated, what the paper is really going to be focused on is how do we separate the values of these physicians and these hospitals in the production function, right? So this is kind of the motivating graph for what's going on here. Okay, so the empirical framework is going to look like this. Very simply, you have patient survival, Y star, IJHT. This is patient I treated by surgeon J at hospital H at time T. And this is just going to be projected onto some production function, G, which is in itself going to be a function of unobserved heterogeneity, alpha J in the doctor, psi H in the hospital, and then XIT, which are a bunch of time-varying patient characteristics, plus some idiosyncratic error. Okay? Imagine for a second that this epsilon, the unobservables, are conditionally independent. Okay? If that is the case, then the expectation of mortality is just going to be a function of the production function in and of itself. Okay? And the comparative static that we're really interested in here is the second derivative of that production function with respect to hospital and physician unobservables, right? That's going to tell us whether in this production function they're complements or they're substitutes. And to sort of see that a little bit more clearly, Pauline, this is a nice graph in the paper, which is if you plot on the y-axis the predicted survival against hospital quality, unobserved hospital quality on the x-axis, and if you then rank surgeon quality by alpha, where alpha 3 is greater than alpha 1, and you can see, and if you see that the slope in this production function with respect to hospital quality is increasing in physician quality, that would tell you, again, assuming conditional independence of the errors, that you have complements here, right? That physicians are complements to hospitals. On the other hand, if you see that the slope is decreasing with respect to the physician estimated quality, then you have substitutes, right? Essentially, this would imply that the marginal return of a higher quality hospital is larger for lower type surgeons, right? Putting a higher quality hospital in a surgeon in a higher quality hospital has diminishing returns rather than if you put a lower quality surgeon in a higher quality hospital, right? That's the basic comparative static that she's after in this paper. And what she's going to be thinking about after this is how do we take the model and estimate it in a way that we can estimate all these alphas and these psis and plot it in a way to figure out what actually is going on. Okay? So how is she going to do that? So observed 30-day survival is going to be simply a function of the potential 30-day survival times DIJHT, which is just going to be an indicator for where you were treated in the data, which is going to give you this estimating model of, the production function plus the error. So the first challenge that it's going to have is estimation. Okay, how are you going to specify the production function is the biggest challenge here. Now, ideally, if this were me and I were writing this paper, I would basically just start by throwing a boatload of physician and hospital fixed effects. Okay, standard two-way fixed effects stuff. However, I didn't write this paper, someone better did. And so what they realized is that if you do this, you run into a lot of issues. One is that there's extremely high dimensionality. There are a lot of physicians and hospitals in the world. And so this is going to pose a computational problem. A second problem is that the outcome of interest here, mortality, is actually quite rare. Again, the average is about 4%. So there's going to be a ton of noise in your estimated fixed effects. A third problem that's related that I didn't actually put here is you have this incidental parameters problem, right? To the extent that most physicians don't actually practice in multiple hospitals, you're just going to find no information about them, right? Okay, so the solution here is that Pauline is going to be inspired by this BLM literature on group fixed effects, which I'll be honest, I didn't read too much about before reading this paper, but I dove into it and tried to educate myself a little bit. Basically, without going into too many details, you could read her paper for that. What she's going to do is she's going to calculate each provider, that's physician and hospitals, risk-adjusted survival rate across the panel by simply just projecting, mortality against like a logit model of patient characteristics. That's how she's going to risk adjust. And then she's going to group providers into several types based on their risk adjusted survival. And then, so that's going to be like a classification step. And then she's going to estimate her model using group fixed effects within these types. Okay. There's a lot of assumptions that need to be satisfied in order to, yield consistency and things like this. I'm not going to go into that too much. Suffice it to say that Pauline does a really great job in the paper at going over those and I buy it. But the basic logic without going into on here is that you're grouping providers by type. That gives you a lot more variation within, and it allows you to estimate these interaction terms in a way that greatly reduces the parameter space and is still consistent under certain assumptions that Pauline. Now, identification is going to be the next challenge. So in these papers, how do you separately identify physician from hospital quality, especially if they're sorting? So first of all, where does the data variation come from? In classic two-way fixed effect models, you basically just need to observe surgeons performing at multiple hospitals, or in the labor literature, you need to observe workers, moving firms. Here, not only do you have those movers, so you observe surgeons who work at one hospital and then go work at another hospital, you have something which Pauline calls multi-homers, which in this setting is really interesting because you have private practice physicians who aren't necessarily affiliated with a particular hospital, but have admitting privileges at multiple hospitals. So you would practice observe them doing surgeries at multiple places throughout the year. And to the extent that there's variation in the quality of those places, that gives you a lot of nice identifying variation. So you can see that variation here, right? If you take a look at the share of surgeries in the sample that are performed by single homers, so people who just only perform in one place, it's about 60% of the data. And then the other 40% is kind of split into traditional movers, those who kind of move from one hospital to the next, and then those multi-homers, which represent about 20% of the data, who are not unaffiliated, but practice in multiple locations because they have admitting privileges in all these other hospitals. Looking at this in a different way, you can see that throughout the panel, about 60% of surgeons practice in one place. The other 40% practice in 2 or more hospitals. And even within a given year, you still have about 20% of surgeons performing in more than one hospital. So quite a lot of data variation to identify those kind of two-way fixed effects models. Okay, so this is where the data variations come from. We still have an identification problem though, because obviously patients can sort into hospitals based on underlying health status and stuff like that, right? So in other words, that, where you observe treatment is going to be is not going to be orthogonal to the error term. So what's Pauline going to do here? She's going to turn to the discrete choice literature, use her Medicare claims data, and essentially just use a type of distance instrument. What she's specifically going to do is she's going to estimate a discrete choice model of demand for hospitals using her claims data. She's going to do that as a function of hospital fixed effects and distance from the hospital. She's going to, I'm simplifying it a little bit, but she's basically going to predict choice probabilities, take the residuals, stick them in her main specification as a control function. And in so doing, you're basically just controlling away from the determinants of hospital choice that are not driven by distance, which we think of as exogenous. So the idea being, if you believe that distance to hospital is an exogenous driver of hospital choice and everything else is endogenous, this should simply correct for that kind of selection in the context of her second stage. I want to note here that there is a surprising, in my view, finding in the paper, which is that there's kind of no relation, like this does nothing, it turns out. Once you stick these control functions into the specification, nothing changes at all, which kind of implies that like conditional on the observables that she throws in for patients, kind of there's no unobservable selection, which I'm not disputing, I'm just saying it's surprising. So it's something that I'll return to a little bit later in my comments. But for the time being, after Pauline shows that this doesn't really move anything a lot, she's going to rely on her main specification that's explicitly identified via selection on observables, right? So she's going to assume the errors are uncorrelated with the treatment, conditional on, again, unobserved physician and hospital types, and observed patient characteristics. So what she's specifically going to estimate is this equation here. The probability of mortality as a function of observable patient characteristics and these alpha size now at the group level by group type. And I think she estimates 5 types, but there's a bunch of robustness stuff in here too. Okay, so that's the main estimating equation. We talked about how she deals with the dimensionality problem. We talked about how she deals with identification. Let's now talk about the results. So remember earlier when I showed those complement and substitute graphs, what you should expect the slopes to look like in either case. Here's what she's finding. So this is the analog of those graphs I showed you earlier. Predicted 30-day survival is on the y-axis. On the x-axis is the hospital group rank. And then the surgeons groups are the different lines, right? And what you can see is that the slopes are clearly decreasing in surgeon rank, meaning that surgeons and hospitals are substitutes according to these estimates. Indeed, the worst ranked surgeons, according to the model, would yield the highest benefits from being sorted into top performing hospitals, whereas top performing surgeons yield the smallest benefits in a pretty monotonic way, which you can see in the table to the right here. Okay, it's decreasing with surgeon rank. As far as the question of how they sort ex ante, you clearly see positive sorting according to the estimates. So if you rank hospitals in these bars from worst to best, you could clearly see that the top performing surgeons, which are given by these maroon shades, are sorting themselves into. So in as much as we might think that the benefits of being in a top hospital are going to be largest for the lowest performing surgeons, we in fact do not see that in practice, which I think should surprise basically nobody in this room. Okay. So why is this? Why do we think that they're substitutes? Well, Pauline proposes this theory called failure to rescue, which is essentially as follows. Top hospitals are well-oiled machines that have these procedures in place that basically save patients when complications arise. These complications are probably more likely to arise when low-quality surgeons are performing there. So if you're a high-quality surgeon and you're in this hospital, these complications are probably less likely to happen, and if they are, the surgeon can take care of it. But if you're a low-quality surgeon and you have an oopsie, the hospital, the technical term, the hospital is going to be able to save you, to resuscitate you, because again, right, failure. Okay, with that, I want you to keep that in mind for later. With that information, let's turn to some counterfactuals. What's going to happen next is Pauline is going to run about 10 minutes, right? I'm at half an hour? Oh, okay. Okay. So what Pauline is going to do next is she's going to use these estimates to test a bunch of counterfactual allocations. She's going to do two things. The first, she's going to randomly allocate surgeons across hospitals. And then she's going to, instead of positively sorting them, which we see, she's going to do the opposite. She's going to negatively sort surgeons in the hospital. She's going to take the lowest quality surgeons, that's estimated by the model, put them into the top quality hospitals, and keep iterating until every single surgical slot is taken. Here's what she's going to find. Random reallocation is going to decrease mortality by about 7%. So as I mentioned earlier, currently we are performing worse than random. Negative associated matching is going to decrease mortality by a whopping 25%. This translates to between 200 and 800 lives saved a year within Medicaid, which is pretty good if you like lives saved. And then she's going to do a couple of other things, thinking about what happens if you relocate within an HRR rather than nationally. She's going to find pretty large gains too. So that's the paper in a nutshell. She's going to conclude by saying returns to high survival hospitals are larger for lower survival surgeons, which again is going to imply that there's a key role of the institution here. Again, thinking about the big question at the heart of this, what is the role of the actual firm? She's going to find a pretty huge one. And then again, counterfactual reallocations are going to save a lot of lives. Okay, that is the paper here. In the last few minutes, I want to turn to my discussion, and I just want to kind of start by saying, like I said this up top, I really love this paper. I loved reading it. I love thinking about it. I love the way it's laid out. I love how careful she is with all of her econometrics. I didn't really go into it that much here, even though it's an econometrics conference. That's probably because I'm the worst econometrician in this room, so you probably don't want me to do that. But everything here, it's one of these papers where you're reading it and you say like, oh, but maybe she should try, and then it turns out she's like already tried it somewhere in the appendix. So it's a really, really great paper. Everything is really clear. Everything is careful. I think this is a really policy relevant paper because thinking about where to put surgeons is extremely important. And if we're doing worse than random, I think that's a pretty striking finding. I have a couple of broad comments about this paper and a couple of very minor ones. So I'll start with the broad ones and then we'll go from there. So I want to start by talking about peer effects, which I want to acknowledge that in the paper, Pauline explicitly says that we're not thinking about peer effects, but I actually do want to think about it because I think it could be quite important in this paper. Pauline tells a story in the paper about how failure to rescue could be one of these mechanisms for what is going on here. I spelled dispositive wrong. It should be with an I. I guess I was thinking of despots or something like that for some reason. But I think that there are alternate stories that could very easily fit this data. One of them is simply peer effects. Low quality surgeons benefit not from the hospitals per se, but from the fact that high quality surgeons sort into those hospitals. So, think about a lot of the literature on taking a low performing student and putting them in a high performing environment. And some of this shows that they perform better. Sitting next to smart people makes me feel a little bit smarter. Could that be because there's a competitive spirit? I hear surgeons are kind of competitive, maybe. Or it could be actual skills acquisition, right? Maybe you learn things from high quality surgeons that you then take with you. This is kind of related to Yijin Chen's work on team building in physicians. Also a typo there, I put 2011, it should be 2021, I think. But the point is that it's kind of hard for me to imagine that if you take the extreme scenario where you take all the top quality surgeons and move them to low quality hospitals and vice versa, take all the low quality surgeons and move them to top quality hospitals, it's kind of hard to imagine that in the long run, this will actually produce gains, especially if peer effects are what is driving this. It seems like if you do that, it would actually do nothing, right? In fact, in many ways, if this is true, I actually am more compelled by the random allocation. Like in some sense, my prior is that randomly allocating physicians would have this benefit of you would actually put high quality physicians and low quality physicians in the same place. And to the extent that that's where the benefit is coming from, I actually think that that might be more compelling than this negative assorted matching thing, especially because, again, we don't really know where this is actually coming from. So related to this point is that in this paper, quality is treated as this sort of static concept, but I actually think it's quite dynamic, and that makes thinking about the counterfactual as a little tricky. So like, as a kind of goofy example, let's say you have two hospitals, a high and a low quality hospital, and you have 5 time periods, and you take a surgeon, and one surgeon has the following distribution of practices: high, 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 low, low, low. Okay? Across the board, low mortality at all of these places. Now, in this model, that's gonna probably map onto a very high alpha J, a really high quality surgeon. They're performing really well across all these hospitals, and so we should move them somewhere else, right? Consider another surgeon: low, 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 high, low, high, high. High mortality until they get to the high quality hospital, and then mortality plummets. This is going to be treated as a low quality surgeon that when put in a high quality hospital, suddenly the hospital has a high fixed effect, right? Here's the thing, they could actually easily be the same surgeon. They're just at different points in time. If you take surgeon 2 and project a few periods more, you could have high, 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 low, 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 and to the extent that that surgeon continues performing well because they think that's something permanently at that hospital, we now have misclassified this surgeon. So what I'm saying is, to the extent that the first surgeon acquired permanent skills at the high hospital, the model would understate the gains of actually keeping them there. The thing that I think unites both of these comments, in my opinion, is that it's kind of hard to think about reallocation when you don't have the micro foundations of where quality is actually coming from. Like, it's not like that everyone just pulls from a random distribution and this is what their quality is, right? They're learning it from somewhere, right? The high quality doctor wasn't born with it. I mean, maybe they're highly dexterous or something, but probably at some point they sat next to a high quality physician or a high quality institution or something like that. And so when you think about it that way, I think that's going to have different implications for the counterfactuals. Okay, I have a couple of probably minor econometric-y things. I'm not going to talk about them now because I think I'm at the end of time, but I'm happy to talk with you about them offline. Yeah, this is all stuff that you probably already thought of, but yeah, we can talk about it some other time. And yeah, at the end of the day, I think this just is a really cool paper. I think what you should do is you should submit it and get a top pub from it, and then write like a structural dynamic paper that tries to figure out the micro foundations of quality. And when you do that, you should email me because that's all right. Thanks.
Thank you so much, Nick. That was incredible to hear your own paper being presented by someone else. This is incredibly useful. Also, you presented the paper extremely well, so I'm marginally relevant now. So we can talk a little bit about your comments, and then I think I would be very happy to take questions. The peer effects. So yes, this is what the paper is not at all about. So thinking about peer effect in this paper, I'm looking at CABG surgery. And because CABG surgery usually is performed when you have a surgeon, a cardiac surgeon, with by themselves in the operating room. And then they have a team of people around them that are not surgeons, who don't have their hands in the patient, but rather you have the anesthesiologists, the nurses, maybe hospitalists at the hospital level. The peer effect is very interesting here because it's not between cardiac surgeons, but it's going to be between a surgeon and a nurse, for example, who's seen this surgery a lot and is going to hand you the right instrument when you need it, or it's going to give you the right suture. So what is very interesting here is that the peer effect is actually between the surgeon effect and whatever is in my hospital effect. Because if you think about my hospital fixed effect here, it's a lot of things. It's all the staff and personnel that is at the hospital level. So that's going to include all the operating room nurses, all the nurses that are taking care of patients after the surgery, all the hospitalists, the anesthesiologists that usually contract with the hospital. That's also going to include management practices. So there are papers now showing that the management of a hospital matters a lot for patient survival. And you can think of the failure to rescue story as really this. If you have a thorough checklist in the OR, maybe you prevent complications from happening if you have a surgeon who has not extremely high survival. So the peer, I think, if you think of peer effects as between the surgeon and something that is in the hospital, I'm kind of capturing some of it in this interaction, right? In this substitutability. And this is even how you can think of it in the mechanism. Something that would be extremely important is when you now think about the counterfactuals, then I agree with you. I'm telling you, we're moving a high survival surgeon to a low survival hospital. I have like tons of warning in the paper being like, this is partial equilibrium. It's by no means me telling you that we would save that many lives if we were to do this. The way I see these counterfactuals is first to tell you, okay, I'm telling you there's substitutes, and I'm telling you there's positive SRM matching. The question is like, can I quantify this substitutability? Should we really care about it? And if you think about the BLM paper, for example, they allow for this complementarity or substitutability between workers. They interestingly find some substitutability for the low wage workers, but it's so small that it doesn't really matter, right, in their paper. For me, it matters a lot. So that's the kind of saying like, we should really care about this substitutability because we would save a lot of lives potentially, or a lot of lives are at stake. The second thing where I think the counterfactual is interesting, and we didn't have the time to discuss it that much, is I have other work with co-authors where we're thinking about sorting of providers across space, right? And I'm telling you there's positive SRM matching, no one was surprised, but it's also like, of course there's positive SRM matching because you have the high survival hospitals that are going to be in the big cities, and the high survival surgeons want to live in the big cities to work at these high survival hospitals. So of course you have positive SRM matching across the country, right? And something that I was really interested in is how much of the positive SRM matching result I find is due to sorting across space. So all these high quality providers are all in the same cities, versus how much of it is due to sorting even within a city. And people had different priors on this, and I was very surprised when I do the reallocation of surgeons within a region, which is a hospital revenue region. I find that more than 50% of the gains could be achieved by just keeping the surgeon in their region and just asking them to practice at a different hospital, which I think is interesting because it opens a new avenue for policy. Because maybe, and I think France has been doing it a lot, CMS is doing it a lot, we're trying to attract surgeons to practice in underserved areas and rural areas. And my takeaway from France is that they're giving a lot of financial incentives, but it's been very hard to attract these high quality doctors to these areas, especially young people. Well, maybe we don't have to. Maybe we can tell them, like, you can still practice in the city you've chosen, but can you at least 2 days a week practice in a different hospital? And this is where the multi-homer thing, I'm sure I've heard it somewhere. I don't think I can claim that that's my concept, but this is where the fact that surgeons already multi-home, already practice at multiple hospitals within the same week or year, we can leverage this and saying like, well, like instead of practicing 7 days a week at the Brigham, could you go half of the week in this community hospital, a bit an hour away from Boston? And if you have peer effects, and this is what would be super interesting, is like maybe this surgeon is going to teach all the other surgeons and nurses how to do this surgery better, and then you're going to actually just increase the quality of everybody, and then it's going to be great. And yes, random sorting would be interesting there. I think I have 4 minutes. Let me see what else. So this is the peer effect. Okay, and the dynamics. So yes, in the paper, you have to assume that the quality of the surgeon is the same, the quality of the survival, the value added is the same for the 7 years of data I have, so it's fixed. I'm gonna run some robustness check taking 3 years, and then like seeing if for the remaining 3 years I would predict the value added there. What is very interesting is, and we didn't have time to discuss it, is so I extract the value added of surgeons and I extract the value added of hospitals. What is very interesting for surgeons is that you can correlate it with other things at the surgeon level and try to see what predicts the fixed effect of the surgeons. And what I find is that you have a strong correlation with experience, which is once again not into the medical literature, where surgeons who do this surgery specifically a lot in the period before I'm measuring everything are actually better at it. And because the volume they do within my time period is relatively constant, that makes me feel a little bit better about not having drastic change in value added or quality of the surgeon. And also I'm only on surgeons who finish their fellowships, right? So they've done 4 years of medical school and then they've done cardiac surgeon 2 to 3 years of fellowship. So they're out of this. They've practiced a lot already. And they perform surgery when they're in the fellowship. So they're not in training anymore. Yes, I think then I'll open to questions and I'm happy to talk more afterwards.
I think Edward had a question.
I am Edward Norton from the University of Michigan. I found this fascinating, both the estimation of the relationships as well as the counterfactuals. My question's about the counterfactual. And when you do that, do you adjust for volume? So to simplify things, we have in the US a lot of small, low quality rural hospitals and a lot of large, high quality urban hospitals. And if you take high quality surgeons and move them to low quality, low volume hospitals, were you assuming that their volume stayed the same, or did you shrink their volume down so they're only treating a few patients, but very, very well? Because that would greatly affect your results.
So all the capacity constraints are constant, meaning that I'm reallocating the spots, the surgery spots, but the number of surgeries that are performed at a specific hospitals are kept constant.
Okay.
And the number of surgeries that a surgeon is constant also. So I'm just telling you, well, there's a spot in this operating room in this hospital, you're taking it. But I'm not necessarily reallocating the entire activity of this.
Great. So if you take a high volume surgeon and put them in a low volume hospital.
Until I have no spot left in that low volume hospital, and then I move to the next type.
Okay. All right. I see.
I'll go over here to Matt. I'll come back to Park.
Hi, Blaine. I'm Matt Harris from University of Tennessee. I don't know if this is a feature that your data allows, but I figured I'd at least ask it. That can you, in addition to like the measures that you use, can you see cause of death for the people who passed away?
I think I can see cause of death. My interpretation of this is that people usually don't want to use it because it's really hard to say what is the cause. So maybe in that case for this surgery it's fine. I stuff on cancer. It's really hard to know if it's which cancer. You have breast cancer, then it's a general cancer. I think what you're aiming toward is like, can you tease out the failure to rescue mechanism, and can you tease out a mechanism and what's happening?
Actually, what I was thinking is if you could, there might be certain causes of death that were like multiple resistant staph or something like that. That's probably more directly attributable to the quality of the hospital and the quality of surgeon. And if the cause of death is primarily, you know, what heart failure, like things like that, then I just it's a great paper. I'm just trying to put on my referee two hat for a moment. And say, you know, okay, are there additional peculiarities that you can pick at to try to empirically carve out more of that hospital specific quality story?
Absolutely. Something that is interesting that's not in the paper yet is that I've tried. So by the way, the failure to rescue mechanism, I didn't invent it at all. So for the story, when I found this substitutability result, I was very surprised. I came to surgeons and I asked them like, well, I explained to them the result and I told them like, does that make any sense to you? And none of them told me like, well, of course, we know this, we've known this since the 90s, we call it failure to rescue. So I was like, okay, so I caught up on the medical literature. So something I could do is keep my grouping on survival, right? So I have high survival surgeons, high survival hospitals, but the left-hand side variable in the 2 fixed effect model could be another outcome. So I looked at length of stay and hospital spending. And when I run this, what is super interesting is that indeed the high survival surgeons or lower length of stay and lower spending, right? So you don't have complications, so you don't have to stay as long in the hospital. There's not that much spending. When you look at a hospital, the story is different because when you look at the low survival surgeons in the high survival hospital, they have a higher spending at the higher survival hospital than in the low survival ones. And this is where the failure to rescue story comes in, where like, well, yes, the low survival surgeon operated at a high survival hospital, but the length of stay was long because there was a complication. And even though the hospital is really good, they really tried to rescue that patient and the length of stay was increased. Same thing for spending. So I'm super interested in any idea you would have to help me show this mechanism because I think this would be super interesting and it would be really like putting the experience of surgeons into the data, like trying to verify that what they really, because all surgeons I talk to tell me, like, of course, and we know who are the bad surgeons in the hospital. So I can tell you that we need to pair them with a specific nurse because they're gonna help them, which I thought was very surprising. Yes.
Hi, Partha at Hunter. I have two questions. One is about patient sorting, right? So cabbage, if I understand correctly, is done as an emergency procedure fairly often, but also as an elective procedure. So I don't know if you leverage that. So distance matters. When you went to the hospital in the ambulance, that's the story. So they take you to the closest one. That's when it's a powerful instrument. But if it's elective, and especially with these people who practice in multiple places, you're in their practice, they're making judgments about where you should go to the hospital on the basis of all kinds of other things. Distance rarely ever matters in those situations. But it allows you to identify kind of two separate margins, I think. So I don't know if you've exploited that.
A little bit, but yes. So most of the cabbage surgery is actually elective in the sample because you have to be, the idea is that you have to be fairly stable to undergo 3 to 6 hours of surgery. So you cannot be in the middle of your heart attack. I estimate everything excluding emergency because with this idea that their distance is gonna be, using distance as an excluded instrument here means that distance can predict the choice of hospital by patients, but it cannot predict survival. So I was a bit worried about this assumption in the case of emergency, right? How far you live from the hospital might then determine how much you're gonna survive. So you exclude them, the results are the same. I would just say the distance to the hospital, even for elective cabbage surgery, is highly predictive of the hospital you're gonna choose. So it increasing, I think it's increasing 20 kilometers, the distance between a patient and a hospital decreases your chances of your probability to choose that hospital by half. So it's highly predictive.
So the second question is kind of just about the mathematics of mortality, right? So it's a bounded above variable. You're starting with 0.92 and you can only get to 1. So in some sense, you can't have diverging rates. You just have to have converging rates, right? So this is conceptual in part, is substitution on that mortality scale about showing straight lines that converge versus straight lines that diverge. In that case, they just can't diverge when you start at 0.9 something and you can only go to 1. But maybe there should be another scale. And you just hinted at something that may actually answer that. So if you have outcomes that are not bounded, like length of stay, then maybe leveraging those to
Exactly,
understand
yeah.
whether in fact they are converging. I'm a little concerned that they are not converging, right? I think you're finding that they're converging because that top line has to
Is-
be pretty much flat.
So yes, so using these other outcomes, I also find substitutability, so it doesn't seem to be that effect. And something else to see, of course, we all have the logit function right in mind, so you see that here it should be like getting closer to 1. It doesn't have to be the case in the data. I could tell you a story where you could have a divergence closer to it could be extremely hard to move from the average survival to like 99% survival. And only the most skilled surgeons would be able to go from 95% to 96%. So you could have a complementarity. It's harder to detect in the data because you're so close to 1. But you could still have a complementarity there, which I think was why this question was interesting in general, because I could come up with a story where, well, you have to be extremely skilled as a surgeon to take advantage of robotic surgery in the operating room and move your 95% survival to 99. Turns out, no, it's raise the performances of the low survival surgeons.
Hi, really nice paper. I had 2 questions. One was thinking about like the selection and sorting of patients into surgery, and there was a margin that I was more worried about than that I didn't hear discussed, so I want to ask about it, which is like, this is a time period where we see declining use of CABG and increasing take-up of stenting. And so there's this like kind of complicated dance, right, for CABG to happen. It has to be that like we, like the doctors, sort of like the doctors that could perform the stent, either don't think the patient is appropriate for the stent, or the like there's this kind of complicated negotiation, I guess, between the interventional cardiologist and the cardiac surgeon. And so whom the interventional cardiologist is willing to intervene on will matter for the selection of who I think probably ends up with a CABG. And then there's like the quality of the anesthesiologist, which you've been sort of discussing, but it's this kind of like trio of who's willing to accept the patient and perform a procedure on them that's going to determine who ends up there. And I'm wondering if like you can actually maybe get at that margin with like different, if there's different rates of the sort of substitution between CABG and stenting at these different centers, whether that can help you understand that margin of patient selection a little bit more. I don't, it's a little bit vague still.
No, that absolutely makes sense. Yes, that's the Chandra Steger paper, right? There are comparative advantages in some treatments for some hospitals. So who gets into CABG in some hospitals versus other, who would get a stent. So here in that case, so that's why I really wanted to try to exclude the emergency patients, because then the margin of treatment enters there. For elective CABG, when I talked to doctors, they told me like, well, we have very common, clear guidelines on when a patient is a candidate for CABG. We need to find like, I think it's more than 2 or 3 blockages, and the patient needs to be a certain age. And it would be the cardiologist who would diagnose the patient with all these blockages and tell the patient you need CABG surgery and refer you to a surgeon. So I'm hoping when I focus on non-emergent patients that I can get away with the next selection, get away from selection into treatment in that case. But I agree that I could do more by leveraging the different rates across hospitals to see how much of this would enter to start here. But here I'm thinking of it as like you were a good candidate for a CABG, you were sent by a cardiologist, and then a cardiac surgeon ends up operating on it.
Thanks, that's really helpful. My second question was like, I think I was taking away that like it would be better to like fire the bottom quintile of surgeons than to close the bottom quintile of hospitals. I think we have a lot more hospital closures and like physician surgeon firings, but I'm just sort of conjecturing. But like I thought that set of implications was really interesting to pull out of your work.
Thank you. Yeah, and that's interesting because my takeaway from the report card literature is that when surgeons were made aware of their performances compared to their peers, the very low performing surgeons stopped doing CABG entirely, and maybe that's what should be done. The good thing is that if you see the number of surgeons who are in this very low group, it's not that many. So that was reassuring to me at least. There are different size these groups. So the 4 groups I have 5 groups in the main specification. the four top groups are more or less equally sized. The low group is much smaller.
I think it was Seth. And I should like it to you.
Seth Richards Schubik, Johns Hopkins. I wanted to ask just the intuition on identification, since getting the complementarity is crucial here, and that doesn't emerge from the traditional two-way fixed model, which just naturally imposes substitution. So from glancing at the VLM paper for 30 seconds, it seems like there's an assumption of finite latent classes. And so my question is, can you give us the intuition for how identification would break down and why that wouldn't be a concern in this application?
Where identification comes from the surgeon that move across hospitals, right? So as long as I can see a surgeon practicing in multiple hospitals, I can separate the surgeon from the hospital. And then I can
But this
separate
is a question more about the method, because if
The
it was a two-way fixed effect, the movers don't identify that, right? The two-way fixed effect identification story, using, I guess, means, imposes
So now it's not
substitutability.
individual, so now the identification is not at the individual surgeon, right? It's at the surgeon group and hospital group. So what you need now is not a surgeon moving across two different hospitals. You need a surgeon in a group moving across two different hospital groups. So the identification changes a little bit.
Yeah, I just don't have intuition for that. Again, I'm asking you to sort of, can you explain how that would break? You know, like if we say there aren't groups, there has to be an effect for every individual, it breaks. So I know that in a limit it breaks, because you can't have latent classes, one per individual. But that's a, pathological case. Can you tell me some other way that it breaks? That would be maybe a more reasonable concern, but again, why that doesn't apply in this application.
It applies, so that's where the assumptions are very important. So so we're grouping in a first step, a crucial assumption I have, and I'm grouping on a specific moment here, which is average survival, right? So I'm computing the average survival at the hospital level, and I'm classifying my hospitals based on this. A crucial assumption here, because the point of this paper is to tell you that the survival at a hospital level includes a hospital effect and a surgeon effect. And then in this average survival of the hospital, I also have the surgeon sorting effect. So here, the key assumption is that I'm going to assume that the average survival at a hospital is increasing in the hospital type, data type. What that means is that I need to be able to separate hospital types based on their average survival. So what I don't want to have, so if you have positive SOM matching, you can see how this assumption is going to be satisfied, right? If you have negative SOM matching under certain conditions, it might fail. Meaning that I would observe two hospitals that have the same average risk-adjusted survival. One of them would be a top hospital with the worst surgeons because there's negative SOM matching, and one would be a very bad hospital with the best surgeons. At the end, because they combine and there's negative SOM matching, they might have the same average risk-adjusted survival, so I cannot separate their types. This would fail. And so I need a very specific amount of negative SOM matching to not be able to separate these two hospitals. And what I would do in this case is lump them in the same type and then estimate on the type. What this does is that it would tend to bias downward the covariance, bias downward towards zero. So I would tend to find no sorting because I would misclassify my hospitals, and the same for the surgeons.
All right, I'm gonna let y'all continue that conversation at lunch. And I know there are more questions from the audience, so this is great. I'm gonna let Michael tell y'all where we're going.
Thank you.
Thanks, thanks, everybody. Yeah, so. So we have an hour and a half for lunch, a little bit less than that now, but I just wanna let everybody know we've got lunch in the back, and then you are free to roam around the building, but let me give you a recommendation. We have reserved the 9th floor terrace. It's a beautiful day outside. So if you want to, you can take your lunch and go up. The elevators are right back here. The 9th floor terrace. And we can have lunch up there and chat up there some more. And then we'll be back at 1:50 for the next presentation. You can leave stuff in here. This will be